It was quite interesting. Nobody mentioned the SAP scanner in all of this, the serum amyloid P. Are you aware of this, and is this what's the role of that method in this whole thing?
Actually, from my side, I have no experience of that because it's forbidden in France because it's using human proteins, and we cannot use it in France. So, to my knowledge, it's really used in UK, for example, and that's a good tool for the whole quantification of the amyloid burden in the light chain amyloidosis in the whole body. So it's interesting for that to have kind of tools to follow the amyloid burden. So that's helpful for the whole body. It's not really efficient for the heart, and because that's why I don't know well it, because I'm not using it in France, and it's not really useful for the heart. But in practice, it's used to quantify the amyloid burden in the whole body and to follow the response to the treatment.
Is it used in Germany?
No, it's not used in Germany.
No, that's a really specific tool used in some countries because it's using human proteins, and some regulation does not allow to use this kind of techniques.
Thank you.
You're welcome.
Hi, I had a question. I'm Lori Lauder from the Amyloidosis Foundation in the United States. And Dr. Rukin, you mentioned several biopsies, but you did not mention bone marrow biopsy.
Mm-hmm.
Where does that fall into? I mean, I would think that would be.
Whenever you have a bone marrow biopsy, you should do congruent staining when you find a plasma cell clone, or when there's suspicion of MGUS. We usually routinely do congruent staining, yes. And we find amyloid there. And I haven't shown the data because we're currently reviewing our case series, which is more than 100 cases, bone marrow biopsies. We find both types, AL, but also ATTR, and that needs to be separated. And ATTR usually deposits in the periostal adipose and connective tissue, while AL is more common in the bone marrow itself. But yes, whenever, and bone marrow biopsy indeed is a regular a biopsy protocol when you have an MGUS. So yes, you should always look for you should always stain for congruent and look for amyloid.
And as hematologist, if you are suspecting an AL amyloidosis, we are always doing both fat biopsy and bone marrow biopsy to increase the probability to have the answer from the pathologist for the diagnosis.
I have a question to you. Do you use the artificial intelligence in order to analyze ECG and echocardiography?
So for the ECGs, to my knowledge, there is not so much tools, but for the echocardiography, there is a lot of tools arriving for the interpretation of the echocardiography. I'm working on one with a big center in Paris, and there, yes, we are using this kind of tools. I think that can be helpful for center without a big experience in the field of amyloidosis, because I think that can for example, gives kind of red flags saying, oh, this is maybe amyloidosis. So we have this kind of tools for the echocardiography, but also for the bone scintigraphy.
Did you have a contact on that with the Mayo Clinic? Because we recently have been at the ISA Congress, and they showed us that they work specifically with the combination of the cardiography and the ECG.
Yes.
On support of AI tools.
So I don't have contact personally with the Mayo Clinic regarding this kind of tools development, but a lot of teams are working on the development of this kind of tools, and I think that there is a lot of promising results in this field. The main issue for me, there is 2 points. The first one, it's most of the time you have the echocardiography on a kind of network. I mean, at the hospital, the echocardiography, there is a digital storage of the echocardiography. This is not the case for the ECG. And so sometimes it can be hard in practice to make the link. That means that you have really nice publication showing that using artificial intelligence on the ECG linked to the artificial intelligence on the echocardiography, you can make the diagnosis. But after that, in practice in France, for example, the ECG is on a paper, and you live with your paper, and there is no digital storage on your personal file. So that's the issue, I think. And the other issue is that for the artificial intelligence, for example, for the echocardiography, who is saying this is amyloidosis? It's the physician, okay? So I'm gonna say, okay, this is not, yes, this is, and so that means that at the end, the gold standard, it's probably the physician. And if you look at the publication in the field of cardiac amyloidosis, I'm talking only about cardiac amyloidosis, the profile of the patient changed over the last 10 years. That means that 10 years ago, we had patients with more pronounced disease. And now, even if we see a small increase of the wall thickness of the heart, we say, oh, this is maybe amyloidosis. That means that the gold standard, which is the physician, it's moving. And that's why I think that this kind of tool of artificial intelligence can be helpful to detect the really advanced disease, or not advanced disease, but the really, pronounced high burden of the disease, but not for the beginning of the disease.
Thank you.
Hello, my name is Rosalind Callahan. I'm from Amyloidosis Ireland. I have hereditary amyloidosis. First of all, thank you for your presentations today and for the work that you do. Patients like me appreciate you very, very much. What I did want to ask was, I'm so delighted that you talked about the extent of detective work that's needed. And I just wanted to highlight that for me, I have minimal cardiac involvement. I'm going into year 7 of the condition, and my nerve conduction studies, the standard nerve conduction studies, don't show any fiber involvement. It only shows in the small fiber tests. So I wanted to ask you about your experience of that in clinical practice, because my diagnosis, I had the benefit of the National Amyloidosis Centre in London, but I could have been missed as a patient because it's not registering in the standard tests. It did register in the Congo red staining from the carpal tunnel surgery. And to add on to what you said earlier, my surgeon in the north of Ireland said that I was the first amyloidosis patient he had met in 40 years of practice.
There you go.
So I just wanted to ask, in the real world, how far do you take the nerve conduction studies, like by listening to the patient? And also, much is made of the erectile dysfunction symptom for the male patients. You will know as experts the sexual dysfunction applies to females. Is that discussed? Is it a question that's asked? And I just wanted to flag that up, that I think that's an area that's missed in the diagnostics.
May I comment? You're very nice. Thank you very much for that your talk. May I comment on that? I've been on that busy for a long time, and first we went to a neurologist with regard to TTR, and then I asked the average neurologist, how many patients do you see with amyloid? He said, well, 1 a year. And when we changed our approach, and when I realized that TTR is very common in the carpal tunnel, I said, we should go to the hand surgeons. And then we made talks at the hand surgeons. So I said, first contact is the hand surgeon. First contact of the patient, the neurosurgeon. First contact is the orthopedics. Since we have done that, the number of cases exploded. They weren't aware of that disease, simple as it is. While the neurologist has the problems, peripheral neuropathy, there's so many differential diagnoses. You have more than 20 different differential diagnoses with regard to peripheral polyneuropathy. So and diabetes, the top one. Then there's some inflammatory types, and amyloid is the very low end. So they see many patients with polyneuropathy which do not have amyloid, so that's their problem. So you need to contact those physicians who really see the patients first. And if you do that, such as hand surgeons, they see the carpal tunnel syndrome, then they need a network. So who's my cardiologist I can refer to, or my hematopathologist I can refer to the patient? I think that's what your talk pointed out, that networking, that there's a network of physicians around that, hand surgeons, for instance. When he refers to them, which also had responses from patients and physicians, and well, now I have a patient with carpal tunnel syndrome who has amyloid, I contacted the cardiologist, said, what shall I do with that patient? Wrong answer. So you need to train your cardiologist. If I refer a patient to you, at that time he may not present with cardiac symptoms. That's a problem. Your disease was, you've red flag, but the disease may show up a couple of years later. So you need to recall the patients 1 or 2 years later. Is there still no problem with the heart? So.
So very important question. If I can add something, I think that usually the neurologists, when they are seeing patients with peripheral neuropathy, of course, most frequent diagnosis, diabetes or alcohol consumption, and etc. But they are asking to do an electrophoresis of the protein. But sometimes, as you say, it's only small fibers. And so patients are coming to us sometimes with normal electromyography, and you have to search to ask a pseudoscan. You have to work with specialists, with neurologists that have seen patients with AL amyloidosis, and they will ask a pseudoscan to see the small fiber if they are normal. Sometimes you have to do a biopsy, of skin biopsy, to see the abnormalities of the small fibers. And a very important point, you have to ask the good question to the patient, and sexual dysfunction or postural hypotension, those symptoms are very important, and we have to ask that to all the patient where we are suspecting neuropathy and amyloidosis.
Yes, I have a question about the cardio biopsy. When exactly do you do that? Because in my case, for instance, there were no signs of cardiac involvement. No, not in the blood, also no in the echography or the MRI. And my cardiologist said, we don't do a biopsy because even if we don't do a biopsy, we can never be entirely sure there is cardiac involvement because we can be 1 centimeter next to where it is placed. So we decided not to do that. But when do you decide you do that?
Yeah, that's a good point. The main point is that what is the gate entrance? I mean, what is the symptoms? For example, if you arrive in the disease with the kidney, we are going to do a biopsy of the kidney. If you arrive with a neuropathy, we are going to try to do nerves biopsy or abdominal biopsy or other. I mean that, and if you arrive with a heart disease, we are going to try to avoid to make the heart biopsy if we can. Mm-hmm. So we are going to start by extracardiac biopsies. And at the end, we are going to perform a cardiac biopsy if we have no choice. But that means that if you don't have any signal of cardiac involvement, we are not going to perform the cardiac biopsy. And that's particularly true in the field of light chain amyloidosis because there is really patchy deposition within the heart. And when you arrive to the heart, it's quite hard to focus on the specific part. I mean that you arrive with, most of the time depends of the centers, but we use the vein approach. So we are going to arrive in the right side of the heart, and we try to make a biopsy of the septum, which is the part in the middle of the heart. And this is only a part of the heart. So if there is no evident burden, if there is no evident heart involvement, and because we suspect light chain amyloidosis, it's a really patchy disease in the heart, you can have normal heart biopsy, and that's not rule out the amyloidosis. So we try to see where we will have the more efficiency of the biopsy to do the biopsy at the good localization.
Okay.
A question regarding AL diagnosis by you and your network. So can you share with us some tendency? First of all, on the number of diagnoses you perform.
For light chain?
Yes.
So in my center, it's not so much we are doing, I guess it's between 6 and 8 patients per year, which is not so bad actually. I mean, not so bad. I mean, it's no. No, but that's mean because these patients are there, and if you are not doing this 8 diagnoses, that means they are still here, but they are not diagnoses. That's why it's not so bad. But no, I mean that no, you know, that's a really weakness, because if we only have 8 patients per year, that means that I see 8 patients per year. So that means my level is not so high. First one. And the second one, that means that my colleagues around me never see light chain amyloidosis. And all the time they said, oh, this is probably, for example, for the heart. TTR amyloidosis, we don't need to look for light chain amyloidosis because we never see light chain amyloidosis. So that's a weakness, because this is a rare disease and we don't see so much. In my center, it's between 6 and 8 per year.
Maybe in Belgium? Do you see a tendency of increasing the number of diagnoses, or quite flat?
We see a tendency of increase, and I think that it's because there is no treatment in transthyretin amyloidosis, and so we have more patients coming from the cardiologist. So it's a very good thing, and meaning that when you know the pathology and you know the sign, you will, and the information is important to give to the specialist. And but we are also a referral center, so of course we have more patients, and I think that for complicated case it's important to work in network and to send the patient to referral center, because as we can see with different testimonies, sometimes you are missing, doing not the good diagnosis. The patient we saw was referred as diagnosis of multiple myeloma. He came in rolling chairs for an autologous stem cell transplantation. At the consultation, in 2 minutes, I know that it was not a multiple myeloma, but an AL amyloidosis. So it's important, and there is also, we are working together with the French group participating to discuss the case with Arnaud Jacquard each 2 weeks, and it's very important. But yes, we are seeing an increase of the case, even if it's still a very rare disease, and it's why it's important to concentrate the patient.
And the second question linked to that, regarding time to diagnosis, do you see a reduction, or?
For some patients, yes. Unfortunately, this afternoon I will present our last case, last week. So a patient coming with multiple organ involvement and heart involvement, severe dysautonomy. 2 days after she came, she was on monitoring, she did her heart arrest. Fortunately, in 2 minutes, she was rescued and there was no complication, but meaning that there is still patient arriving very, very late in the disease. And it's true that we have more patients that are arriving also earlier after the onset of the symptoms from the cardiologist most of the time, and we still to give information, a lot of information about the disease, and to continue to do these jobs is very important.
Just to complete, to be able to compare between, in my center we are doing 5 new diagnoses of ATTR per week. So it's between 6 and 8 patients with late chain amyloidosis per year, and 5 new patients per week with ATTR amyloidosis, and among them it's 15% of patients with variant. That means that so it's not exactly the same numbers, and because there is an increase of the awareness of amyloidosis with ATTR amyloidosis, in my center there is an increase of awareness of amyloidosis in the wide term of amyloidosis, and we are increasing the rate of the diagnosis of late chain amyloidosis. And we saw a little an improvement in the delay, but obviously there is still too late patients.
Thank you.
Yeah, so Mark McConway again from Amyloidosis in Scotland. One thing that I was very interested in when you were showing the team that was involved, it struck me that this might be a rare form of this, but I wondered if there was a role for ophthalmologists in this, and I'll explain the reason for this. And second to that, I wanted to find out how well data is shared amongst the international scientific community about this, looking for early markers. So that's the preface, and I'll just explain. So I have systemic AL amyloidosis. Now, 10 years before I was diagnosed with this, I had ocular occlusions in 5 of the retinal veins in my eye. It was catastrophic. Now, fortunately for me, I did recover sight in my left eye after about 18 months. Now, at the time, when I went to the hospital, I was aged 48. It was very, very unusual, and they were telling me that for somebody my age, they just couldn't explain what had happened. So I had parked that for probably 12 years, something like that. However, obviously, after I was diagnosed in 2011, I had chemotherapy. I was obviously keeping an eye on, and excuse the pun, but I was keeping an eye on what was happening in relation to amyloidosis. Now, only 4 years ago, I discovered an academic paper that was written by a Serbian doctor about 2 episodes of ocular amyloidosis. And as I was reading it, I thought, oh my goodness, the symptoms were almost identical to what I experienced 10 years before the diagnosis of systemic amyloidosis. So my question was, how do we know that there are not hundreds of people who had exactly the same experience in their eye, which subsequently manifested itself as systemic amyloidosis? So sorry for the long journey, but that's really the point.
No, that's a really good point, and that's the case. There is a lot of people without diagnosis, and it's not only late chain amyloidosis; it's rare disease. It's 5% of the population with rare disease. 5%. That means that you cross 100 person, you find 5% with rare disease, and I can tell you that on this 5%, 4 don't know they have rare disease, but they have symptoms. They have an issue, but nobody knows that. That's why we need a really good network for rare disease, for amyloidosis obviously, but amyloidosis is a part of rare disease, and I don't know in the other countries, but in France we have a dedicated plan for rare disease with network for rare disease. And I'm doing amyloidosis, but I'm doing rare cardiomyopathies. And the patient when the patient arrives, they don't have amyloidosis. They have cardiomyopathy or symptoms. And that's why after I have to suspect amyloidosis, but sometimes it's another rare disease. And that's the case for your ocular issue.
Thanks.
And the problem it's a rare symptoms in a rare disease. And so it's even...
My counter to that is that it's maybe not rare. It's just that it's maybe not diagnosed, or it's not.
Yes,
not
yes,
known
but
about.
if you ask to the people with light chain amyloidosis, you will see that maybe we didn't, we are not able to make the diagnosis of light chain amyloidosis among patients with this kind of symptoms. But if you consider the other side, patient with light chain amyloidosis, this kind of symptoms is quite rare. That means that it's probably rare inside a rare disease. I agree with this point.
Okay.
As you want. Yeah, is there still odd questions? Yeah.
Are there also candida infections that are identified by their amyloidosis that they cause sometimes?
Can you repeat? I didn't hear.
There are candida infections which are identified by their amyloidosis.
I don't think that at the time of diagnosis is specific. I have to say that I have a recent patient that had that infection in the story of her disease before the diagnosis, but it could be a complication of the treatment because you will give sometimes steroid and immunosuppressive drug that will act against the plasma cells, but that will also decrease the immunity of the patient, and it could give some infection, usually more bronchitis or pneumonia or something like that, but you could also have candidose and candida infection.
One question to you, Professor Röcken. You showed all this interesting data and many of the data points obviously provided by your team or derived by your team. Do you have any suggestions about sharing that data or do better data sharing with other institutions like yours in order to have even more data and have more insights into these diseases?
All the data have been published, so we share them and present them on talks. But in the end, not every pathologist will provide diagnostic in that spectrum. So there are always some specialists like me. And no. Sorry. Close up. Sorry. Okay. Well, we publish a lot, so that's how we try to show our experience and give talks like today to share experience. Not every surgical pathologist will have the capability and the interest to do the diagnostics we do. They're happy that I'm there in Germany because we have 3 or 4 surgical pathologists in Germany who are somehow specialized on this diagnostics and know that. And it's a problem if sharing the expertise I have is very difficult. I have juniors, I show them, but it is a lifelong expertise you collect. But coming back to you, I mean, we have made really, being here is already a success story. Seeing you here is a success story. So I think the awareness of amyloid is increasing worldwide. And the networks are there worldwide. So you have been in London. I know the London team also for 30 years. So we have many European initiatives. One is here now today, but there's an EPAN group with interest in proteomics, which members from Italy, Denmark, Sweden, the Netherlands, France. So I think we have an increasing network worldwide with a special interest in amyloid.
So, thank you all, and I think that it's the time for the coffee break, so have all a good congress.